All right, we're going to try and do a fast facts version of our education series. Couple reasons. One, I've got 11 studies to go through and I don't want to do them all that in depth. And two, I want to explore if this shorter style content where it's more bullet points is going to do better for, well, you, the listener. So, starting from the top, we have the relationship between shoulder muscle function, and is there a particular direction that we find improves disability? When they looked at this study, they found that being able to move the shoulder out and improving the ability to move your shoulder out improved disability more than flexion, more than other movements within this own study. So when we're taking a look at patients, one thing that we may want to consider is measuring your ability to move your shoulder out to see if you're likely to be getting better underneath our care. Now, next up, we've got one that's helping the case for spinal manipulative therapy. Aside from the public sensationalism about talking about neck adjustments and stroke, another one that is sometimes talked about is leaking cerebrospinal fluid when you adjust. And so this study took a look at, do you actually leak out cerebrospinal fluid if you have anything with a cervical adjustment? And this one said no. There was no significant association. Like here, I'll go to the sentence. There is no significant association between spinal manipulative therapy and cerebrospinal fluid leak incidence or risk compared to other interventions. So it's not that big of a deal if that's something that you're truly concerned about. Now, we still go through an informed consent, but again, there's no really greater risk than anything else that we seem to do with patients in that regard. Next study on my ticket was the reliability of manual muscle testing, specifically with a technique called AK. And they found that depending on where you pulled the source from, it was either no correlation or association with reliability all the way up to extreme, which again shows some bias when it comes to research. I have my own biases. That is, unless you actually measure it objectively using a tool, it's next to, you almost may as well not have done it. It's a very poor screening tool in and of itself. Like my physicality versus anybody else's physicality, when you're comparing a patient's subjective muscle strength, there's so much difference between, a 5 foot, 6 foot, 7 foot, 100, 300 pound provider manually holding a muscle to test it and saying, oh yeah, that's 1 through 5 on a scale, that's 3, that's 5, that's 4. It's all over the place. So if you're going to manually test muscles, like I do, we use tools. We use technology so that we take our physicality and bias out of it as much as possible, so that it is only the patient interfacing with the tool to get an accurate number of their capabilities to give us diagnostic information, as well as a fantastic way to audit progress under care. So the study, as far as reliability of manual muscle testing, specifically with AK, combined with previous studies about manual muscle testing not being that great, reinforces that same point. Now we're on to study 4. Physical activity is protective, especially in mid to late life, against dementia. Food for thought there. Study after that, shockwave compared to standard physiotherapy in proximal hamstring tendinopathy. If you have a good graded program from a physiotherapist, there was no difference between shockwave therapy and conventional care and physiotherapy. The only difference in the study was patient satisfaction was higher with shockwave, and that could be for a lot of other reasons, such as shockwave is a tool that you feel. If somebody's doing it right, you will certainly feel it, which could tie somebody's perception of getting better with them feeling that temporary discomfort while the actual treatment is happening. Again, not really knocking shockwave. There's a time and place for it, but like many tools that I see, it sometimes is too much of a shotgun approach or panacea. So that's why we need a lot of different tools and approaches with patients so that we can match the right one for the patient in front of us. If you just claim that a shockwave device treats everything, you've kind of lost the plot. If you say it's really good for conditions A, B, and C, or patients D, E, and F, that's great, that's fantastic. Then we have other ways to help patients in other cases. So when it comes to proximal hamstring tendinopathy, some people hear the term, I need to go get shockwave because it's tendinopathy to improve it. Well, this study just showed physiotherapy has the same outcomes. Now, you might be willing to pay somebody more because you like the process of it to get the same outcome, but in this economy, maybe just consider that food for thought. Next study, dry needling versus instrument-assisted soft tissue mobilization in patients with cervicogenic headache. The important bit is that it's a cervicogenic headache. Both found utility in this study, having improved outcomes in patient satisfaction, range of motion, disability, pain, etc. I do believe the study said instrument-assisted slightly outperformed in subgroups, but again, both did very, very well. So that comes down to me talking about, just like the last study, patient selection. And as long as we're appropriate with our patient selection and do a good informed consent, then we have a bunch of different ways to approach cervicogenic headache. If you're a person that prefers to have dry needling done and you have a pretty restricted motion throughout the neck, might do dry needling. If you're somewhat restricted, but you're more on the painful side and you're unsure about needles, on top of other exercises, if we choose to use manual therapy, we use an instrument-assisted device, we're likely to get you better. So again, gives us flexibility in being able to choose the most appropriate the most appropriate treatment for the patient in front of us. All right, like I said, this is fast facts. So if you have any questions, please comment. Next up, lumbar paraspinal muscles in patients with chronic nonspecific low back pain and the effect of exercise. So one of the things that we see with pain is people will often become deconditioned because they avoid certain activities. And one way that that is assessed, especially with chronic low back pain, is the back extensor endurance test, where you basically do a reverse plank. So if a plank, you're working your core because you're fighting gravity, this one kind of flips the script and props you up on a table so that you're now pulling yourself up using your back muscles. And compared to healthy norms, so you, but not in pain. So if you're 30 years old, 40 years old in pain, take that same 30 or 40-year-old without pain. People without pain have a higher endurance time, and it's one thing that we can do to screen. It's a quick and dirty one where if I take a room of 100 people and we do that same test, the people that score more poorly, aka don't have as much back muscle endurance capacity, are more likely to be the ones and in chronic pain. This study basically showed if we take that and improve somebody's ability, aka, I'm saying aka a lot, if we put them through exercise and then test this as their time, their endurance increases, their pain is in an inverse relationship, it goes down. So basically, if you're deconditioned and we get you conditioned back again, while strength isn't always the thing that's going to get you out of pain, in this situation, in this study, it was the thing that was able to be correlated or shown to improve. What I'm trying to say is, outside of nuance, if this is just a black and white, if they improved your back muscle capacity, you had less pain. Now, let's get back on track because I have 4 studies left, and I want to make sure that this goes out to you all in a timely manner. Is motor weakness in cervical radiculopathy an indication for surgery? Not always, no. In fact, outside of a few higher risk factors, most people got better with conservative care when it came to motor weakness with cervical radiculopathy. So conditions stemming from the neck that are affecting the arm, and this one motor, so your ability to move or strength in the hand, wrist, forearm, etc. 2 to 3 months of dedicated conservative care had most people responding very, very well. About the only people that they highlighted that had a worse probability of getting better with just conservative care, and you may want to consider surgery, included higher risk of participants with 6-month non-recovery timetables. So that's not the risk factor. That's people who didn't get better in 6 months. Here's what they saw. If you were older than 59, and if you had a less favorable improvement in the markers that they were measuring, like 2-point discrimination when it came to sensory, motor strength using a modified medical research scale. So if you weren't as strong on this scale, like particularly weak, So really, like, not just, I feel, this is like, oh man, you pick up somebody's arm and it just drops dead. So an initial very low score on the motor strength and poor 2-point discrimination touch. Long story short, if you want to sum these up, if you had really bad neurosymptoms of the radiculopathy, you had a less good chance of recovering. Okay? So it really comes down to you discussing with your provider and them doing a thorough exam, seeing where are you at right now and what are your odds of success in the next couple of months. If, in this one, you were younger than 59, had a modest level of motor strength and had some sensory capability, 2 to 3 months conservative care, you were rocking. You were doing really, really good. If you were older than 59, had really, really, really noted motor weakness and couldn't really distinguish between 2-point touch, so your nerve function was really impacted, then it may be a sign that we should put you into surgery to get better outcomes. So it's not a black and white field. We really have to just assess the patient in front of us. Where are they starting from? What are the odds that they will get better under our care versus what might actually be better for them in the long run? So while I want to make sure that everybody gets the best care possible conservatively and we save the surgical cases for surgeons, we have to really make sure that we guide each person appropriately. So if we think you got good chances, we'll tell you, we'll work with you. If you hit some of these risk criteria that they highlighted here and we're not the best fit, we need to tell you, and vice versa. That's how, actually, no, I'm going to start getting into a rant if I do this. So I'm going to move on to the last 3 studies. See, I'm prone to wanting to go into rants, but we got to keep these fast facts. Spinopelvic alignment and mobility are not currently associated with low back pain in healthcare workers. So healthcare workers, one benefit of being a healthcare worker is you typically get easier access into imaging studies. And one thing that they wanted to take a look at, because it's also endemic within the healthcare community, is low back pain. And they noted that when a nurse in this research example had back pain and they took x-rays for it, one thing that is often measured on x-ray, no matter the profession, radiologists will note pelvic alignment or obliquity, just noting essentially the quality of the study and if there's pelvic unleveling. These are just standard markers that a lot of radiologists will go through. Some practitioners will take that noting, oh, there's significant unleveling, that must be a reason for their pain. No, not necessarily. There's a ton of reasons that this snapshot of a person on an x-ray could have, pelvic unleveling. It could be legit anatomy, whether it's pathological or not. So if it's pathological, in this instance, I'm meaning it is a reason to cause their pain. So it could be pathological pelvic unleveling. Okay. Could be non-pathological. Could be just a normal anatomical variant. Could be just the person is in pain at the moment, so they're shying to one side, which will, when you take the picture, make it look like one side is higher versus the other, when in reality it's not. It was just because that person wasn't in a great position when they took the x-ray to begin with. So in this study, they took a look at the people that reported pain and then compared it to their x-rays to see, hey, was pain and pelvic unleveling, were they correlated strongly together, so where we could say, if we take a random x-ray out of a group of 100 people and look at it and it's really unleveled, is that correlated with pain? And no, it's not. So if somebody's telling you that your alignment on x-ray is the cause of your pain, you should probably get a second opinion. Now, last 2 studies. I'm doing pretty good. This is only going up onto 14, 15 minutes, so we are getting faster. This one I could talk about for a whole half hour easy, maybe longer. So let's see what I can do here to keep it short. People that have hypermobility conditions, legitimate hypermobility conditions, to the point where you're on the hypermobility spectrum disorder, or you think you have a condition called Ehlers-Danlos syndrome, rather than being just sought or thought of as a connective tissue disorder, there is a significant overlap with autonomic symptoms and conditions to the point where we can no longer just think of these hypermobile patients and Ehlers-Danlos patients as musculoskeletal only patients. There's so much overlap with other co-diagnosed autonomic conditions and these same patients suffering autonomic symptoms that these spectrum disorders should be considered autonomic in nature until proven otherwise. So in this study, that's what they wanted to posit, that there's such significant co-diagnoses of these conditions, they should be thought of as not just purely musculoskeletal, evolving the management that these patients go through. Rather than just seeking an orthopedist, they should now seek like a potentially rheumatologist and or endocrinologist to help navigate and mitigate the disability and symptoms that they suffer. That's all I'm going to say for that one, because I will go into a very long rant otherwise. So last study in this fast facts version. Manipulation and therapeutic exercise applied to the neck region patient in the adjustments in soft tissue and exercise. If performed on patients with temporomandibular disorders, does it help? Yes, but again, only when it's combined therapy. Adjusting on its own won't help TMD. Soft tissue alone doesn't always help. Exercise alone, while still the strongest thing you can do for it, a lot of patients will benefit from providing that window of relief that manual therapy can provide. So when you're able to combine everything for the patient, we hear about, you must be a sniper. Well, sometimes being a sniper isn't always what's required. Sometimes you got to take the shotgun approach, give them everything to give them the best chance to get better. So in this one, adjustments with exercise and soft tissue for people with jaw disorders helped improve their ability to open their jaw, their pain, etc. So I still want these fast facts to get even faster. I want to start getting to the point where I will generate bullet points and I'm just reading them off to make this content faster, more digestible. And I think the reason that this one was particularly long is because it's been about 3 weeks with the holidays and the New Year since I did this. So if you like this shorter format where I'm hoping it'll be sub 10 minutes for here on out in the future, please let me know. If you don't, also let me know. But I'm going to try and reserve longer form content where I can give more of my thoughts in a more podcast format rather than just on a YouTube format or a short little video format like this. So let me know what you think. Thank you for sticking with us, and until next time.